although we wish we could see you all in person. We're having a little Zoom overload, I'm sure all of us at this point. So welcome and Happy New Year to you all. We will spend a little bit of time introducing our program since we'll have some new members of our work group on today. We want to make sure everybody has a little background on our organization. We have the team from the Ontario Econsult program out of Bruyere Institute in Ottawa joining us today, and Dr. Liddy, Alex Hajar, and Claire Setharam will be joining us and speaking to their recent publications. We want to introduce our clinical advisors, the clinician experts in Econsult who help us so much in guiding our work. And we want to hear your stories too. So we'll save a little bit of time at the end to hear from you, any recent successes you'd like to share with us. I've said this again, and I hate to repeat myself, but thank you so much for keeping yourself on mute since we have a large number of people on the call today. If you want to pipe in through the chat, thank you. That would be great to hear from you in that way. So every month we meet on this webinar. We have 50 or more people on these calls. We have over 200 organizations participating in our work group, and we welcome new members all the time. So for those of us who might be joining us for the first time today, we really appreciate you taking the time out of your day. This is a hard time for everyone. We understand, especially those of you who are providers, treating patients, dealing with the pandemic. Thanks for taking time out of your day. We want to be able to provide resources for you to provide better access to care for your patients. So if you haven't visited our website, econsultworkgroup.com, this is a compilation of your stories, your resources, your examples of how you have incorporated Econsult in your practices. So thank you for sharing those. I'm just going to make sure everyone's on mute so we don't get any background noise there. We also want to note that we have a playbook of those stories and practices and examples you've shared with us. So make sure you take a look at our new website. This was launched just a couple months ago. If you haven't been there for a while, there's new material every month. So thank you all, those of us who are new, or those of you who are new. And thanks for keeping yourselves on mute. I'm just going to do a little mute there. I do want to do a quick shout out, a thank you to our funder, California Healthcare Foundation, for making this work possible. Thank you, CHCF. And thank you to our sponsors, both our 2020 sponsors who really made our virtual annual meeting such a success in November, and to our sponsors who've come in for 2021. Thank you for supporting all of our work. I'm going to say this optimistically, looking to November 2021. I hope I get to see you in person. We've had 5 in-person wonderful meetings with you all and 1 virtual one. So let's just hope in November of this year we get to see each other in person once again. And it's our sponsors who really make this in-person meeting possible. Being able to network, share stories, maybe enjoy a beverage together and get to see each other off of Zoom. So thank you so much for all of your support. With that, I think I'm going to just get on with our work today. We have clinicians on our call who I'm sure have things to do in terms of treating patients. And I introduced them at the beginning of this call, but we have Dr. Claire Liddy, Alex Hajar, and Claire Setharam, who are from Ontario. So it's great to note that we really do tap into international examples of Econsult success. We started as more of a California group, but we do really appreciate examples from across our country and from Canada. And Dr. Liddy's been an expert in our work and just been advising us from day one of this effort. So thanks for joining us again. We always like to see new presentations from you and your team. And with that, Dr. Liddy, I think I'm going to hand up to you and allow you to introduce yourself and your group and tell us a little bit about your work.
Yeah, thank you very much. Thanks, Libby. And I mean, it's very mutual. I think we've been working together for years. So we're going to give a little snapshot, and I am taking the opportunity to just show 3 or 4 slides that gives you a sense of some of the work we're doing in Ontario and Canada before handing over to Claire, who's going to talk specifically about the primary care provider survey, and then I'll hand over to Alex, who's going to talk about the work that he did in vascular surgery and e-consults. Claire and Alex both were summer medical students with us. And then Claire's actually, I think, been with the team for 3 years now. And Alex, I'm sure, will be invited back. So there's so much to look at. So I'll just get you to go to the next slide. So my background is actually, I am a family doctor and in fact, Econsult in Ontario. and now we've spread across Canada, but it really was born out of one of my patients. I complained to an endocrinologist, Dr. Keeley, who's my co-lead and co-creator of the service that we have in Canada, that it was taking way too long for her to basically see my patient. So that was back in 2008 that we had that conversation, which brings us, fast forward, really happy to be here and again presenting some of our results. Next slide, please. Just acknowledging the collaboration. So as with many of you, we do have a strong collaboration with funders, and now in particular, some research grants still, which I'll just give a snapshot, but in Ontario, it now has been funded as a program. So I've been able to take it from a research project into full program funding, and Canada is completely Medicare, so it's universal healthcare coverage, so it's completely funded through public funds. So that's where we're at in Ontario. This slide just shows, again, that's Erin Keeley actually on the left and myself on the right from a few years ago. And again, bringing it back to that we talked about what the issues of access were really over a cup of coffee. And we at that point had no idea that we would end up thinking about using this type of a service. And I have to say, I spoke with the folks in California at University, UCSF, very early on when I had seen about the e-referral system that was developed there. So next slide, please. Again, just a snapshot of what we've done over the last few years in our region. And one of my big messages for anybody who's starting out is be patient, you'll get there. As I said, it's been very exciting to just work through this system. And then we basically have incorporated a mandatory survey in our Econsult service as it's moved on to program level, which is one of the things when Alex shows his results, he'll be able to speak to, but it has really created a great learning health system opportunity for us in Canada. And for those of you who don't know Ottawa, which is where I'm from, it's the capital of Canada, and Ontario is one of our provinces. And just go to the next slide. I think I've got the map of Canada. We're a province of about 14 million people in Ontario. Canada is roughly 38 million, so much smaller than the US, but and even smaller than, I guess, your population in California, but we do cover large geographic distances. And what's been really interesting since starting this work, and I just wanted to give you a snapshot so you can reach out to colleagues who are maybe more in the West for you, and we've been able to do significant spread and scale of Econsult across all of Canada. And in particular, the updates now are that the province of Newfoundland Labrador, which is in the east and very rural population, province of New Brunswick, Quebec, and then I'm presenting Ontario, and also Manitoba, all have full provincially funded, publicly funded Econsult services available to their populations. So it's very exciting work, and it's making a huge difference in terms of the access to that immediate or very rapid specialist advice for our population. Next slide, please. I just wanted to show you where we're at in terms of if you're a family doctor in Ontario now, who you can access. And it essentially covers the full breadth and depth of any specialty service that and subspecialists that you would like to be able to send an e-consult to. And we have just gradually built this up over the years. So we started just with the idea of endocrinology, and then immediately we're told by our family doctors who participated in the very early trials that you need to offer more than that. So we built from 5 and then went to 20, 30, 50, and now, as you can see with our provincial level service, are offering access through eConsult to many different specialty groups. Our most popular in general still for our region are dermatology, endocrinology, cardiology, and GI are the ones that are requested the most. Move on to the next slide, please. What we've done now, and just a snapshot of our data, what's the volume like now? So 7,000 cases, that was across a monthly pattern. This shows a year by year data for all of the e-consults. And with COVID, we've had a huge increase in uptake and adoption by primary care providers to try to get access to Econsult, because obviously, I'm sure as you have, we have significantly reduced in-person visits. So things are not quite as bad here, but we're well into a bad second wave at this point. And again, family doctors are retracting, and specialists as well, those in-person visits. So this one, I just wanted to let you know that what we did was just use the, I think it's called the Power BI dashboard again on, and we collect the data, and we can do very rapid updates on these dashboards, again, just to break it down to specialty service. We break it down into different regions and share all of that data so that the different areas that we're working with can then be responsive and understand what the data is like in terms of Econsult. Next slide, please. Just about there. So I just wanted to share with you that we're doing a lot of research and looking at, and in particular, invite anybody to follow up with me if you're interested in frailty, if you're interested in the application of natural language processing to the Econsult data. We're putting together some grants on that. We enjoyed learning all about how you're using Econsult in corrections settings, and that is actually rolling out in Canada, and then quite a few other areas of interest as well. So really happy to work with anybody or share any of the information that we have here. We do have, I just noticed at the end that you were going to talk about your patient partners. So I just want to share that we have adopted a person-centered patient partner approach on all of our work with Econsult, and have at least, I always try to have 2 patient caregiver or citizen partners on any of our research programs, and also on our program level committees. And it really has helped, I think, keep folks grounded and identify what the priority areas are. So next slide, please. And with that, oh yeah, I did want to highlight, sorry, just want to highlight the work that we're doing in long-term care or nursing homes, and put a plea out that it has been hugely impactful, and very popular service, making a huge difference for those residents. And again, in Canada and in Ontario, they are so restricted now because of COVID, and being very affected by COVID in terms of high number of death rates. It's a really sad environment, but Econsult can offer a glimmer of hope in terms of getting that access to care. So if you're not thinking about using it and you haven't engaged with physicians or nurse practitioners who are working in the long-term care nursing home setting, I would just encourage you to think about that. And again, we did a proof of concept pilot, and we've also taken a look at what types of questions are coming through, so highly valuable. And next slide, please. And with that, I think now I'm going to, I think we can move on. We are looking at corrections. I spoke to that, and I want to hand over. Yeah, that's fine. We'll go over. I'm going to hand over to my wonderful students now. And so over to Claire Sethram, who's going to talk to you about a survey that we've done. And again, we're trying to, within the program now, and the really good news on my side is that I managed to get the government to actually give me some funding for ongoing evaluation, as well as our research funding. So that allows us to take this type of a perspective now, and Claire's going to speak to primary care perspectives for the Ontario Econsult program. So thanks for the opportunity to give you the snapshot, and please email me and reach out if you want to have a further conversation. Over to you, Claire.
Thanks, Dr. Liddy. So yeah, as mentioned before, my name's Claire, and I'm a first-year medical student at the University of Toronto, and one of the student research assistants with the Econsult team in Ottawa. So our study was the primary care providers' perspectives on the Ontario Econsult program. And as part of our ongoing evaluation of the program, we conducted a survey of the primary care providers registered for the Ontario Econsult program, designed to assess their experiences with the service and their perspectives regarding its impact on their ability to provide care. So next slide. We conducted a 24-question web survey of all PCPs registered for the Ontario Econsult program, which is available to all primary care providers practicing in Ontario. The survey was open from the end of June to August 2019, and distributed to 7,718 PCPs. The survey explored their opinions in 3 key areas: experience with the service, remuneration, and recommendations for enhancement. And the survey was anonymous and completed on an encrypted survey platform that meets all necessary privacy standards. Next slide. A total of 1,256 PCPs completed the survey, resulting in a response rate of 16%. And of these survey responses, 78% of PCPs had submitted an Econsult before, 14% had not, and 8% did not specify. And when asked to identify the main reasons for participating in Econsult, the 3 most frequently selected responses were reduced wait times, ability to access specialist advice for patients who are unable to see a specialist in person, and reduced need to reach specialists by phone. Next slide. So the first area we explored was experience with the service. And the majority of PCPs, about 88%, stated that their overall Econsult user experience was very good or good. And the most common Econsult questions submitted to specialists included topics pertaining to treatment plans, diagnosis, and drug management. And about 67% of PCPs indicated that they complete Econsults themselves without any administrative support. Next slide. So this is important because at the bottom of this chart here, we see that only 22% of PCPs stated that Econsult increased their workload. And just up a little bit, 52% had no trouble integrating Econsult into their clinical workflow. And back up at the top of the chart, we see that 74% of PCPs agreed that Econsult improved their referral decision-making. 73% agreed that it increased their ability to manage diagnoses. 69% agreed it improved care coordination. 82% agreed that it increased confidence in the care they are providing to their patients. And 61% agreed that it broadened their specialist network. And most PCPs, about 72%, felt they received adequate training, and 66% receive adequate technical support. Finally, about 70% of primary care providers found the Econsult service to be user-friendly. Next slide. So the next area we explored was remuneration. Primary care providers using the Ontario Econsult program can be remunerated when submitting an Econsult for a payment of $16. 56% of PCPs reported using this billing code, K738, when submitting an Econsult. 37% of PCPs feel adequately compensated for using Econsult. 30% of PCPs proposed higher rates of remuneration, with suggestions ranging from $20 to $100. Finally, 31% of PCPs clarified that they were not compensated for using Econsult, either because their position does not allow for compensation, for example, they're salaried, or they were unaware that they could bill for the service. Next slide. So the last section of the survey explored recommendations for enhancement. And the most common recommendation was better integration into clinic workflow, such as EMR integration, which was listed in the top 3 ranked responses by 68% of primary care providers. Other suggestions included adding more specialists from the PCP's region, making the service more user-friendly, and creating an app optimized for use on tablets and smartphones. Next slide. So study limitations include a low response rate of 16%. And this non-response bias could be due to the fact that the survey was only available for 8 weeks over the summer and may have limited the ability of all PCPs to participate. Despite our survey's large sample size and broad geographic scope, it still remains limited to a single province, and therefore it may not be generalizable to other settings across Canada. And lastly, the study is susceptible to recall bias, as PCPs were asked to comment on cases that may have been completed several months prior to submitting the survey. Next slide. So finally, our main conclusions from the study. Primary care providers expressed an overall positive experience with the Ontario Econsult program, highlighting the fast response times and improved care delivery as some of the main benefits. The majority of PCPs did not experience increased workloads after adopting the service and had no trouble incorporating Econsult into their clinic workflows. Primary care providers' opinions on remuneration were quite mixed, with just over half of PCPs receiving remuneration for submitting e-consults. Improvements to further streamline the service's use, particularly through EMR integration, was commonly indicated to be a desirable improvement. So thanks everyone so much for your time. And if there's any questions, I guess we can go through them now before Alex presents.
That would be great, Claire. And that I was going to ask if we could pause because we have a couple of things that have come through on the chat. And first, I'm going to read out Dr. Greg Buchert's question, but Dr. Buchert is on right here. So Greg, you can always pipe in too. For anyone who's not reading our chat, it says, regarding long-term care, if a resident leaves a facility for face-to-face specialty visit, they may be forced into lockdown isolation in their room for 2 weeks as a result of leaving. Econsult in LTC can make a dramatic difference in those residents' lives. And I wanted to share a question, but Dr. Buchert, anything you'd like to add?
No, I think that's more of a comment, but having seen this in person with a couple of residents where my mother-in-law is, they don't want to go to the doctor because they know that they're going to be isolated again for 2 more weeks.
And it's so interesting you said that, Greg. I was going to say the exact same thing. My mother-in-law is in a residential facility. We can't get her to the doctor. It's so hard we're not even allowed to visit at this point in time. So eConsult proves to be such a value at this point during our pandemic. But of course, post-pandemic too, transporting a patient in long-term care residential facility is so difficult. So even more of a value of eConsult. And another question that Dr. Liddy responded to, these slides are beautiful, Claire. This data is so interesting. And both Claire, Dr. Liddy and Claire, we love to see this, and it's going to be so helpful to see the protocol, your interview or survey protocol. So thank you for offering to share that with our group. It would be great to be able to ask similar questions, right? To compare what we're hearing. We're all experiencing the same challenges during this pandemic. So asking these similar questions would be very interesting to compare responses. Another question that came in, and you, I'm sure, you're well aware of the fact that we have different coding in the US. You know, our CPT code is different than your K code. Do you have a standard reimbursement rate for that K code that you use, Claire?
Yes, yeah. So in Ontario, Canada, for the family doctors and nurse practitioners, the rate is $16 for the person who is the submitter. The specialists are then also paid, interestingly, more because of, I guess, slow negotiations between the doctors groups and the government. It actually still is held by us. So we pay a prorated time-based rate to the specialists. And it's self-reported time. The average cost per case for the specialist to answer is about $50. So it's really still sitting at that, and we do the audit, but it just, the funding for the whole program comes through my actual hospital institution, and we still hold all of the billing payments for the specialists. Eventually, it should be negotiated, but
That's very helpful, Dr. Liddy, to understand those rates, since are vary widely across the US. You know, our PCP rate, our primary care rate is low. Our specialist rate in California is around $32. So everybody understands that this may not capture the value of the time spent. There's another question here that I want to voice because I think this is helpful. Maybe from Dr. Stan Cruncher. If that's you, Stan, feel free to pipe in here. Long-term care and eConsult in the US, the challenge seems to be pathways to remuneration. LTC is not uniformly reimbursed or reimbursed well. Are there creative ideas, Dr. Liddy, of how to address that?
Yeah, well, I mean, I would say Canada is the same. It's such a under-resourced area. So there were two things that we did. One was, again, that they can access the same payment or same fee codes, the providers in long-term care as we have. So we're lucky in Canada because it is, as I said, universal access. So it doesn't really matter where you're delivering your healthcare services. The second thing is we did quite a lot of work in long-term care, I guess, to really demonstrate what the high value was to use Econsult. And so it's extremely, I think you've heard some of the reasons why you might want to use it, but it really has been a huge value added for the providers in long-term care. So it's helping them with their day-to-day in terms of the patient management.
Thank you so much. With that, I'm going to pass to Alex Hajar. I believe you're taking this on, Alex. Go ahead.
That is correct. Thank you very much. Thank you everyone for the invite to come and present this research. I'm excited to present the Vascular Econsult, an efficient, useful, and economic tool for primary care physicians to interact with a vascular specialist. Can we go to the next slide, please? Okay, so the purpose of this study was to describe the use of Econsult in vascular surgery through both the analysis of question type, so what question was asked, as well as looking at user feedback. So looking at what the PCPs had to say about the Econsult service and to get some of their experience. Next slide, please. So what we did is we looked at all of the Econsults that were submitted to the University of Ottawa Department of Vascular Surgery from the time that Econsult was integrated into the practice until June 22nd, 2020. And we noticed that there were 553 Econsults submitted to the vascular surgery service. Now, for all of those Econsults, we did something called a utilization data analysis. So what a utilization data analysis does is it looks at the patient demographics, so patient age, patient gender. It looks at the time to first specialist response. So how long did it take the specialist from when they got notified that they had an Econsult in their inbox to providing the PCP with a response. We also looked at the specialist time spent on the Econsult, as well as the PCP exit survey responses. So the PCP exit survey responses are really important, and there's something that Dr. Liddy alluded to before. At the end of the Econsult, the PCP has to fill out a mandatory case closure survey that talks about the satisfaction that they got from the Econsult. Was it valuable to them? In addition to a few other things. Now, we analyzed that in the utilization data analysis portion of our study. Now, you'll notice here that for 363 Econsults, we were able to do a sub-analysis. So the reason we were able to do a sub-analysis for 363 Econsults is because after an Econsult is completed, the case essentially, so the question that's asked along with any appended images, videos, lab files, in addition to the specialist response, are uploaded and attached. So we were able to look through that, and from there, we were able to look at the actual question that was asked, and we could see what question type was it, in addition to what area of vascular surgery was the question asked about. So that's clinical topic. So for those 363 Econsults for which the data was already uploaded, there were 360 that were complete. 3 we had to omit as they did not have complete data. And with those, we did something called a case-based analysis. So the case-based analysis is the sub-analysis of the Econsult. So again, looking at what type of question was asked and with respect to what area of vascular surgery was the question related to. Next slide, please. Thank you. So we developed our taxonomy based on a validated taxonomy. And you can see here that there were 5 different question types included in our study. So looking broadly, you can see that there were questions related to diagnosis, management, treatment, epidemiology, as well as unclassified questions. And below you can see some examples. So an example of management question would be, what should we do with this aneurysm versus a treatment question, which would be something like, is there a case for endarterectomy here? Would this patient benefit from revascularization? What strength of compression stocking should we prescribe for a patient with venous disease? And below you can see the 14 clinical topics that were included in our study. So you can see aortic iliac aneurysm, cerebrovascular disease, peripheral vascular disease, among others. Now, before I went ahead and coded all of the cases, we did a small pilot of 20 cases to ensure consistency between the raters. And next slide, please. Okay, so as you can see, the number of e-consults increased steadily in the first few years that Econsult was integrated into the practice, with the highest number coming in 2018. You can see a small dip in 2019, and if you look at 2020, you can see that it appears that there weren't as many e-consults sent that year, but that's only because it was a 6-month snapshot of the entire year. If we extrapolate for the full year, we'd expect that there'd be around 130 e-consults, which is sort of what we're expecting. Now, of those 553 e-consults that were submitted to Vascular, the vast majority were from medical doctors, where almost 10% were sent by nurse practitioners. So again, this is really interesting to look at here, these last two parts of the data. Now, a response to an e-consult is really, really helpful when it's done quickly, and that's what we were able to see in this study. So you can see here that the median time to response for an e-consult was 6.28 hours. So that is often within one workday. And additionally, when we presented this research to vascular surgeons, this is something that we highlighted, which was the self-reported specialist time spent per case. So you can see here that in almost 3/4 of all e-consults, the vascular surgeon was able to provide an answer in under 10 minutes. So what's important here is if you have colleagues who are considering joining the service but are apprehensive as they have clinical duties or they have other obligations and they're unwilling to take on another large burden, this would not be a large burden. This is something that provides a great benefit to PCPs, provides a great benefit to patients, and it does not come at a very large time cost to specialists. Next slide, please. Okay, and we talk about the value of eConsult to PCPs. You can see that this is a very, very popular service. So almost all, so 95% of PCPs found the service to be helpful to extremely helpful. And in 49% of cases, the eConsult allowed the PCP to confirm their original course of action. In 47%, the eConsult provided good advice for a new or additional course of action. So this is a service that is not only liked by PCPs, but it also provides benefit to the patients by impacting the clinical course of the interaction. Next slide, please. So when we talk about face-to-face referrals, this is another area where eConsult sort of stands out. So the 553 eConsults we looked at, in 345 of those cases, a referral was initially contemplated by a PCP. However, following an eConsult, almost 70% of those contemplated referrals were no longer needed. And there were 185 cases where referrals were not originally contemplated. However, following eConsult, 20 were now needed. So in addition to avoiding unnecessary referrals, so these are referrals that do not need to be seen by a specialist. So otherwise, these are spots that would otherwise be used by patients who might have a more urgent need to see a specialist, as well as avoiding unnecessary travel for the patients. This service also results in patients who might not otherwise be seen by specialists to be seen. And that has a lot of implications down the road when we talk about cost of care for more advanced conditions. And you can see here that eConsult resulted in a modified PCP referral behavior in roughly 50% or 49% of all cases. So again, eConsult is a valuable service. It's well liked by PCPs, and it impacts patient care as well as referral patterns. Next slide, please. Okay, so when we talk about that second portion of our analysis, so the case-based analysis where we looked at the actual question, you can see that the majority of questions were related to management, followed by diagnosis and treatment. And you can see here, if we look at the clinical topics, you can see it's no surprise really that the majority of eConsults were related to the three topics of peripheral vascular disease, aortic iliac aneurysms, and cerebrovascular disease. If you look to the right, you can see the most common question type asked. So this is the specific question type, so management of condition finding. And that was the same for all of the different clinical topics. What's even more interesting is if you look further to the right, you can see the second most common type of question asked. For example, in peripheral vascular disease, it appears that questions relating to management or when to refer were very popular, followed by aortic iliac aneurysms. Questions were more related to diagnosis, so timing or monitoring of findings, versus cerebrovascular disease. Questions were more related to recommendations of treatment. So for example, you might have a PCP that would ask about a patient with peripheral vascular disease, saying, at what point should I refer? This patient can walk one block. Should I be referring now? This patient has an ABI of 0.4. Should I be referring now? versus aortoiliac aneurysms, it appears that PCPs are more looking for at what point or how should I be following up this aneurysm? What tests should I be using? How often should I see them? And if we think about cerebrovascular disease, we could say this patient has a critical stenosis, their stenosis is 40%, they're asymptomatic. Do you think they need a carotid endarterectomy? So by looking at our taxonomical analysis, it's interesting to see what possible gaps exist in terms of the understanding of vascular conditions and how to manage them with respect to PCP management. Next slide, please. So in conclusion, we can see that there was rapid growth and acceptance, as well as a quite substantial popularity for the vascular Econsult. It avoids unnecessary referrals and saves both patient time as well as money, and it impacts patient management, as I think we showed. As we just mentioned, this study may inform designing future continuing medical education, as well as undergraduate and postgraduate medical school curricula to inform gaps that exist in vascular surgery. And lastly, what it's really all about is Econsult is good for patients. So it results in shorter wait times. It results in more directed care. It also saves unnecessary patient time, travel, hassle, and it helps them get the care that they really need and the right care for them. So that concludes my presentation. Thank you again for the opportunity to present the research. I look forward to answering any questions.
Thanks so much, Alex. And we do have a couple of questions that have come in. And what I love about these slides is it mirrors exactly what we have found across US studies. And our findings are so complementary. We hope that sharing of this research helps us both. So one question that we had come in, I'm assuming, Alex, that the 69% of I'll say avoided unnecessary referrals. I can't remember how exactly you referred to it, but that was just for vascular, correct?
That's correct. That's just for our study and what we looked at.
Great, great. Well, that is an amazing data point. And one question came in from Brent Steinekert. Did the 69% of referrals no longer needed help the vascular surgeons at all in terms of freeing up additional consult slots on their schedule or improving access to care for their in-person consults? And then Brent says he's attempting to address the potential benefit for the vascular surgeon.
Yeah, so I can give my answer, and I think Dr. Liddy might be able to comment on it as well. When we looked at basically the net avoided referrals, we found that over the course of the entirety of the e-consults themselves, there were 217 avoided referrals. So those were essentially empty slots in clinic that the vascular surgeons could fill with other patients. So in that sense, it does actually open up spots in the clinic, but I'll let Dr. Liddy comment further.
Yeah, thanks, Alex. Yeah, we don't have the specific data from this clinic to be able to prove that. And it always depends on how much of a wait list there is. So as soon as you start to free up, then you just there's such a wait list in some of our areas, and vascular is one of them, that I don't think that that's the way to pitch the value. To me, the pitching of the value when you talk to specialists is about having more effective visits. So Econsult can help with your pre-visit workup and then also directs people more appropriately to you so that the patients who you are actually seeing in your clinic were appropriately referred and had the correct pre-visit workup. The other piece that's important, we didn't show this data, I think, but about 3 to 4% of all e-consults, the primary care provider actually reported that it avoided a delayed medical referral. So they were not originally going to refer the patient for a face-to-face visit, but as a result of Econsult, they're now initiating that. So that's also, I think, a good value added. The last point I'll say is that in order to open up the way that we've done our service is at specialty group, you only need to have 2 willing specialists within each of the specialty groups to actually start to offer Econsult. We use 2 just because they can give a backup, but you don't have to onboard everybody to be able to actually offer the access in that area. So we have always gone with our most willing specialists, who really are interested in this and interested in the, I guess, having a better dialogue with primary care providers. And then, as Alex pointed out, it's good for patient care.
Thanks, Dr. Liddy. And those of you who are piping in on these questions, I am trying to interpret some very experienced specialists' questions to you. So I encourage you, I believe this is Stan French's question. Stan, if you'd like to elaborate on your question, taking yourself on mute, please do that. I'm just going to read it here for those who are not looking at the question. So HubMD, I think that's Stan. Have you looked to use the dialogues to ascertain appropriateness of care following guidelines in vascular patients? So I believe, Stan, you're probably meaning like looking at the back and forth conversation between the primary care and the specialist, but Stan, feel free to pipe in here. And then Dr. Liddy, I'll hand that to you.
Yeah, I can answer that. In terms of vascular, no, but it would be a really good study, especially on aortic aneurysm, I think, follow-up. But we have looked at that and done a comparison of guidelines and adherence with neurology. And in particular, we had an analysis where we looked at migraine headaches. And part of it was actually, the question was whether or not could you have used the guideline actually to have answered the question. And we also looked at that with cervical cancer screening and basically PAP results interpretation, and then sort of what your ongoing pathway is. So, so actually, I probably didn't answer your question. What I'm saying is that most cases when we've looked at it, you needed to still ask the Econsult question. So whether or not you could then apply the guidelines back and avoid the Econsult, my gut feeling is no. But more to follow on that. And I would really encourage, again, we don't have a very high volume of Econsults compared to, I know, especially Paul down in LA, you've got a great data set there. So definitely a good question to answer. We do have specialists who will, though, use it as an opportunity for teaching, and they'll, send back the guidelines. And I'm not sure if vascular was doing that. Alex, can you comment on that? Do you have a sense of how often there was an attachment sent back, which actually might have been, here's what the recommended guideline is?
Anecdotally, from just what I remember of collecting the data, it appeared that there was some education by the vascular surgeon. However, I think it was inconsistent, and it depended on the question. But I think, like Dr. Liddy said, that would be an interesting avenue to go down, especially when we think about looking at the educational benefit of the e-consults.
Yeah, I mean, if you just to stand and just to jump in, I mean, if you're already doing the dialogue reviews and doing the work, like it's something that we're doing in urology in a number of different areas. Like it's a pretty simple strategy to take the guidelines as they stand and then apply retrospectively and look and see if the PCPs adhere to them closer over time, like as a way to demonstrate learning if you have the volume on very specific high volume like questions like hematuria and urology, for example. Anyway, just wanted to jump in there, but I haven't seen yet in the literature good data on education, even though we assume it happens. Like it would be a really interesting way to try to figure it out.
Thanks.
Yeah, great point.
And I think it sounds like, Dr. Liddy, you covered the additional question you had there, Stan, but also I want to note, Paul Gibney just referred to Dr. Gibney's work. Dr. Liddy, Paul, if you want to pipe in here, I think everyone can see your comment, but with regard to 40% of requests not resulting in a face-to-face visit, I mean, that's, of course, with the volume that you're seeing from LADHS, that's still an amazing result, Paul, but do you want to elaborate?
Well, I love what Dr. Liddy and team produce here. You guys are so good at analyzing and asking questions. And I really like some of what Alex shared. My impression of what is going on with vascular surgery here at our system is that, the lion's share of vascular surgery requests are for vascular access for people with chronic kidney disease. And these are sick people that need a lot of care coordination, sometimes even before they get to the vascular surgeon. So my impression is that many times our vascular surgeons are helping coordinate care, helping point the patient to the right service line. Maybe they need to see nephrology first, or, and so I think a lot of this pretty large percentage of referral to other specialties in our non-face-to-face group is probably largely coordination around the care of, sick patients who need dialysis access and maybe need to see the nephrologist first or whatever. So, I mean, there's a little bit of speculation there, but I really like what you're unpacking here, Alex and team.
Thank you, Paul. I have one question
Thank
here, looking at your slide, Alex, around educational benefit, and this is more operational for those of us who are not doctors. Do you find that CME is an incentive to get people to join your program? Do you get both primary care and specialists more engaged through the, the carrot of a CME credit?
I think this is something that I think Dr. Liddy can probably speak better to.
Thanks, Alex. To a certain extent, I think the what we're working on now is that a system where you would automatically get your CME credits if you do both for the specialist and for the primary care provider. So I think once they do it, then people do comment on both sides. The specialist side too is interesting because often if you have an internal medicine specialist or a general surgeon, they are getting sometimes a greater breadth of questions that come to them than they might see in office. And so they'll speak about how they actually talked to their colleague or they went and got updated. So it's great. And then for primary care provider, the educational piece is very important, but I think recognized more once they're using the service. So not really something that's going to get people to sign up. When I go out, I just did a talk on Friday morning, and what I do is I challenge the family doctors who I talk to tell me that they don't have anybody sitting on a waiting list. And if they do have somebody sitting on a waiting list, then I basically make them feel very uncomfortable that they could be using this service, because in Ontario, it's free. So, and it's free and you get paid. So you free access to it. We give you everything. You can access 101 different specialty services. So how could you actually leave one of your patients sitting on a wait list without potentially thinking about maybe an Econsult could be a good thing for them? So that really, I think, is the way to do it. And we're trying to get from a policy point of view with our regulatory authorities. So we have sort of our licensing college. They've now mandated it. The other thing we did was I applied and we got approved and we're sort of recognized as a leading practice. So really trying to hit those quality indicators, and again, putting it out there that this, because it's now program level, that really, if you're not using it for your patients when you can, that maybe your quality of care delivery is not at its optimal.
This is such helpful messaging, Dr. Liddy, and I love the message to primary care that if you have a wait list, there really should be no question around participating in Econsult for your patient's benefit. So thank you for leaving us with that way to get primary care engaged, since especially out here in California, we are dealing with major access issues. So yeah, great messaging. And just for sake of time, we're gonna move on to our next few slides, but I know there may be more questions for our Ontario team, and we just really appreciate you joining our calls on an ongoing basis. We hope you'll continue to participate and share your great studies that come out of your program. So thanks again.
Yeah, absolutely. I'll answer the last question. 7,000 a month is where we're at now on a program level. So, and I think the next slide has my contact details. So I am, and we have a website now, or we've another website. So I'm really happy to talk about this, and I think it's amazing also all the work that you're all doing. So thank you for the invitation, Libby, and great job, Alex and Claire. First international presentations for these students, and I think they both did a great job.
Oh, wonderful. Yes, it's just such a rich presentation, and thank you both. Thank all three of you. Please do stay on and share any comments that you have, and we appreciate your resources. Your website too, Claire, we will link to that from our Econsult work group page so that others can see the great work that you do. And with that, we do want to do a quick introduction. Unfortunately, we have a new advisor we want to introduce, Dr. Lisa Arfons from the VA. She had to step away to help with a patient care issue, and we understand that all providers who are on our call today are wearing many hats. So we want to add Lisa to our group and honor her contributions to our group and our team over time. And Dr. Bucher, Dr. Gibney, and Dr. Tua are also on. You've fed into our conversation today. I'll just open up to any brief comments you want to share. Greg, would you like to share any comments just with regard to the work and where we're going this year?
Sure. First, I'd like to thank the people that just presented. It was it's wild to think that it's completely funded for all of Econsult through government funds. Obviously, threw down the gauntlet to the U.S. now to learn from Canada, and well, it's just great to see the work that, and I think the broad perspective that the Econsult work group is looking at. And I think we've got to look no further than just that whole discussion about integrating it into the workflow. It's not a matter of the technology or the people or the things behind it. It's actually helping providers move faster into integrating it into their EMRs and integrating it and getting their staff accommodating those kind of consults. And so again, I think will be a good challenge for us to pick up that mantle along with some of the other things that this group is working on. So thank you all for broad participation.
Thanks, Greg. Delphine, I saw your face pop up, so I'm going to hand off to you. Do you have any comments to share?
Comments. I mean, I always love to hear Claire and her team's work. It always adds to our perspectives and how we can continue to evaluate it. I did have one quick question, or just if there were any updates. I think when Claire, the med student Claire, presented, she mentioned that there was some request for more local specialists to be involved as much as possible and to answer the e-consults. And I'm curious how you guys are trying to incorporate that feedback, if at all possible, because I think I'm a big proponent of trying to strengthen the local ties between primary care and specialty care, using the larger specialty care wherever you can get it if there's no local availability.
Yeah, so thanks for that. What we've done is created regional coordinating groups, and we are actually funding a few local administrators. So there's 5 regions now across our province. And then we have the 101 provincial sort of services available. And as you said, that just means that we've got equity of access. But we rely, and we're engaging with the different family doctors to tell us who they would like and if there's any services. And then also we've gone through the academic departments to try to engage the different groups in the different regions. So when you go on the service now, we did an upgrade, and you go on the service, you can identify what your region is. And then if you would prefer to have the e-consult routed to somebody who is in your local community of practice, if they're available, then you can request that. And we also have, the availability or the ability of the specialist to be listed individually as well. So that is something that really helps work with the local specialists. And then when I go to do the presentations, I point out that you've got these 15 specialty areas, or 25 of them, that are actually your local specialists who are in fact answering e-consults.
That's awesome. I love the idea of really trying to focus on the local community of practice and really identifying those. I think we can really try to leverage that for our own programs out here too. That's cool.
Yes, thank you. And Paul, did you
personalizes it?
Sorry,
so.
go ahead. Sorry about that.
It personalizes it. And then in many areas, especially with chronic conditions like chronic pain, what we've seen now is that often the advice that the specialist is giving back is about, well, here's a local service. And did you know that there's a social worker who, does this, and here's how your patient can access it, and, so on and so forth. So the more we really believe in that regional approach, in particular for the knowledge of who the local resources are for the patients. And that's very helpful for family doctors as well.
Thanks, Claire. Paul, did you have a couple of words in wrapping us up here?
Well, I think along with what was just discussed, I love Claire's first slide that showed that cup of coffee, those 2 cups of coffee. Ultimately, the dialogue in eConsult establishes relationship, right? And a relationship can be very rewarding for both the primary care provider and for the specialist. It can connect them. It used to be in the old days that the doctor's dining room at the hospital was the place that doctors connected. But now providers can connect virtually, even if they're in their same communities, and share resources, share their ideas, and share care of the patient through this platform. And I think that's something that ultimately engages the providers the most, is knowing that that other person on the other end of the line is invested in the same good outcomes for their patient as they are. So anyway, that's just something that I think Delphine's comments played on as well.
Thank you all. And I'm going to zip through my last few slides here, but Dr. Liddy and team and all of our clinical advisors who are on today, we really appreciate your guidance here. So with that, I'm just going to point you to a few resources that we have available and ask for your contributions too. We look to Dr. Liddy, Dr. Tuo, all of you who are publishing this great work to be able to share this through our website. We have a playbook of best practices focused on FQHCs, clinics, health systems, plans, patients. We have different audience materials and best practices. We'd love to hear your stories. Dr. Liddy will reach out to you since it sounds like you have some great patient stories captured. Thank you so much. We would like to hear from you all who are on this call today. We also want to hear about collaborative efforts. We mentioned last month, we started out in Fresno rolling out a program that's now grown to be the Central Valley Econsult Coalition with support from Anthem Blue Cross, HealthNet, and Calviva Health Plans, along with 6 FQHCs and the clinic network in the area. So it's great to hear collaborative efforts from across the country. So please share those with us so we can feature them and learn from them. Last, I wanted to point out what's happening next month. We were so happy to see, although this is not a happy time, we were pleased to see that we have already some great findings with regard to Econsult in response to COVID and supporting primary care doctors to be able to better treat their patients. So Michelle Lee, I think you're on the call today. Thanks so much for joining. We're so glad that we'll have you speak on our next call next month, along with Dr. Namadiri. And please take a look at this article before our call. It was in our recent newsletter. Last, I think we have a brief announcement. Timmy, I know you wanted to mention some outreach we wanted to do. Timmy, are you there? You might
I'm not spamming the chat for everyone with those announcements, but I think in addition to the long-term care, we really want to pick that back up. It's definitely something very close to both Libby and I. So we'll follow up on that and take right where we picked off when we or where we left off when we were working with long-term care and COVID was knocking at our doorstep. But also we want to start exploring more detailed Medicare Advantage and duals billing. So if you either have if you are billing Medicare Advantage and or have your duals enrolled in Econsult, we'd really like to speak with you. Or if you're interested in expanding Econsult to those populations, we would also like to speak with you. So please follow up. Both my email and Libby's email is in the chat. Also, I put the website in our chat too. That's all I have, Libby.
Thank you, everyone. And we are right down to the end of the hour. So thank you so much for your time. We wish you well. Please stay healthy. And we look forward to seeing you next month. Bye-bye now.
Have a great day, everyone.